Hey, everybody. Great to have you here with me again today. I'm Leslyn Keith, and I'm the president of the board and director of research for the Lymphadema Project. But today is one of those 2 Thursdays a month where I get together and talk to you about research that has to do with lymphedema. And so I have another paper I'm going to talk to you about today. And as I'm doing that, wow, I always love it when you post things into the chat. Tell me where you are in the world and who you are, and love just to see who's out there listening. So today, the paper that I have for you today is Efficacy of Liposuction in the Treatment of Lymphedema, a meta-analysis. So a meta-analysis means that the authors looked at all the research that was available in the area of liposuction for lymphedema, and then they distilled it down to looking at certain papers. So I'll talk to you about what their methods were and how they decided which papers to look at to start to get some good information about liposuction for lymphedema. I know that a lot of you are investigating this as an option, and the more you know about liposuction as a potential for treatment, the better. So arm yourself with knowledge. So the first thing I'd like to point out is the authors of this paper, Alexandre Amato and Daniel Beniti, and these are 2 surgeons in Brazil. They do liposuction for lymphedema, but they also do general treatment for lymphedema. You might remember Dr. Amato has published previous papers. He had one on case studies of lymphedema showing that it can be treated non-surgically. And this is pretty remarkable for a surgeon to be saying, wait a minute, we don't always have to do surgery. Here's some other options. So now he's teamed up with his colleague, and they have decided to do a survey of literature and kind of pool all that information from all those various studies to see what we can learn about using liposuction for lymphedema. So, the aim of this study, this review, was to find how effective liposuction is in treating lymphedema, and they wanted to learn whether liposuction really should be recommended as a first-line part of therapy. Early up to late stage. As soon as you get a diagnosis, should this be a route that you're taking and going right to that? So they gave a little background in the paper, and they were talking about that the current treatments for lymphedema are really grouped into either surgical interventions or conservative therapy. So conservative therapy would include, you might have heard of manual lymph drainage, a specialized massage technique, doing compression therapy that might be with pumps and compression garments, skin care, stuff that doesn't involve, cutting into you. So conservative. And those treatments are all used basically to give you relief from your symptoms and hopefully stop the progression of the disease. And so you look at the effectiveness of those treatments by how well they do those things. How do they control your symptoms, and do they stop the progression? So in this review, they were looking for studies that they wanted to have studies that had data on primary outcomes of the surgery, meaning they wanted to have data on pain, on bruising, on quality of life, edema or swelling, and mobility. They also wanted to look at what was the need for having ongoing conservative treatment after the surgery. And they wanted to look at the safety of the procedure. So what were the adverse events, if any? So, the complications, stuff like that. They were also looking at secondary outcomes. So did liposuction have any impact on inflammatory markers, since we're starting to learn that inflammation might be a basis to lymphedema? So did liposuction have an impact on that? Did it have an impact on the progression of those inflammatory markers or inflammatory symptoms? So basically, looking at deeper into what could be some of the outcomes of surgery. So just letting you know what there is several methods of doing liposuction. and you use a cannula to try to remove that subcutaneous adipose tissue, the excess adipose tissue. You're trying to do ways that minimize the blood loss. They started adding wet techniques, so they don't just do the dry liposuction, but they're adding water. And this should hopefully, it's what Dr. Rapprich called lymph-sparing surgery, lymph-sparing liposuction, and minimize that blood loss, and hopefully increase the wound healing and have fewer side effects. So, so he was looking at the studies that they included in this. They had to be in English. They had to show that they had some way of taking data to look at the particular outcomes that they were looking on that I talked about, the edema, the swelling, the pain, quality of life, all those measures. They had to take data on those. And then, so then they started with an initial pool of 531 potential articles. And then they eventually whittled that down to really the ones that met their criteria were 7 papers. So this was just 7 studies that they ultimately included in this review. But even though it was only 7 papers, that the total sample size of all those papers grouped together was 451 patients with lymphedema. So that's pretty good. The average age range in those studies, those 7 studies, was 35 to 54 years old. And the sample size really ranged quite a bit. 2 studies only had 25 participants, and 2 studies had over 100 participants. Interesting, this I found very interesting. 6 out of the 7 studies were all in Germany. How interesting. 1 was in Austria, right next door. So a lot of good research coming out of there. The length of the follow-up time after they had the surgery, and then they would go ask the patient how everything is going. It was ranged from a very short follow-up of only 3 months, and 1 study that followed up 12 years. So you can see there's quite a range in that. Let's see what else. So, and then when they looked at the quality of the studies, 6 out of the 7 had what they called FAIR methodology. It wasn't good, it wasn't superb, it was FAIR. And 1 study out of the 7 was actually poor. And they could not find any studies that were better than FAIR. So this is what they were able to find. So when they put all that information together, what did they find? So just looking at pain, when they put the information that the outcomes of all 7 studies together, there was a substantial and significant reduction in pain. That's but pretty much, I think, what a lot of us have heard. If nothing else comes out of the liposuction surgery, it seems to at least be a big reduction in pain. 3 out of the 7 studies showed, only 3 even looked at swelling. How interesting, because it's pretty often that you're going to have some surgical swelling. So it's kind of interesting that they didn't even look at swelling, but 3 of them did. And all 3 of those studies that did measure and look at swelling, they had a significant impact. Bruising, 4 out of the 7 looked at bruising, and they all reported a significant reduction in bruising in the lymphedema areas. And mobility, only 4 looked at mobility, and all 4 of them had significant impact on mobility, a significant improvement in mobility. You kind of see how that would work. If you, when you remove a lot of excess fat, you can move a lot easier. Quality of life, 5 out of the 7 looked at quality of life. All of them had significant improvement. So then they, as I said, they were looking at how much of conservative treatment, non-invasive treatments, are needed after surgery. Can they wear their compression garments less and things like that? So 5 studies looked at that, and it was a 51% of patients continue to require conservative treatments post-surgery. So they might still be going to get MLD. They might still be wearing compression garments. They might still be using a pump. It didn't say what those conservative treatments were, but a little over half still needed some kind of conservative treatment, which means a little under half did not. That's very interesting. And then safety. Okay, so is there adverse events? Do we have complications? How often do they happen? So only 4 out of the 7 actually reported on their adverse events. That's a problem. I think anytime you do a paper about surgery, you do a study about surgery, you should be reporting on those complications and adverse events. So one of the 7 studies, they said 100% of their patients had a temporary, what they call hemoglobinemia. It's a type of anemia. It was quickly addressed and everything was fine, but 100% of their patients in the study had a problem with that. And 82% had a burning sensation, again, that was temporary and did resolve. And then a lot of the stuff was, it was very few adverse events, but there were things like there was wound infection. There was like a 1.4% infection rate. One person had acute pulmonary edema, which could be pretty serious. Post-operative bleeding, but that was then taken care of. A DVT in one person. Erysipelas, which is a pretty severe infection, that was a 1.4% for that infection rate. So there were adverse events, but again, only 4 of those 7 studies even told you what those adverse events were. So I think that's a pretty important thing to know about. So remember, they had those secondary things that they were looking for that had to do with inflammation. Did the papers report on inflammatory markers, and did we have any improvement in inflammation in the patients after their surgery? And so they were looking at inflammatory markers and progression of those inflammatory markers and symptoms of inflammation. And unfortunately, there wasn't enough reporting on that to really get some conclusive answers. The authors suggest that this is really something we need to look at in the future and keep an eye on inflammation better and see what's happening pre and post liposuction. And then I think a big thing that people going into liposuction are interested about is, am I going to lose weight? And is my body shape going to be improved? For the surgeon, they're mostly looking at, does the pain go down? And if your body shape improves, we want it to be in a way that improves your mobility. That's the outcome that they're looking at. But a patient, quite often, they want to look better, or what they feel is looking better, and they would like to have their weight go down. So, and in these 7 papers that they reviewed, there was quite a varied response. They had some participants that lost weight, some that actually gained weight, and then some that stayed the same. So there wasn't really a conclusive result on that. And then, but all studies showed a reduction in the size of the area worked on and a reduced disproportion between upper and lower body. So that seemed to be pretty consistent. How much of a reduction, it didn't report, but that was all in that direction, whereas body weight was in all directions. So the authors then go on to say there's a couple cautions that we need to bring up. One is this phenomenon does not happen with everybody, and it actually was not reported in any of the adverse events in these papers. But there is a phenomenon where your fat gets redistributed after liposuction. And this is why it's really good to have good long-term follow-up. So if you have all the fat removed, say from your thighs, then maybe it can go instead, if you continue with your same lifestyle and you still are adding adipose tissue, now it may appear on your belly. So, or it might appear on your upper arms or across the top of your back. but somewhere different from where they, did the liposuction. So that is an issue. Another study was not on women with lymphedema, but another study, it showed that fat was redistributed in the participants from the thigh to the abdomen. Later, it showed up in the belly. And another paper talked about 61% of women 6 months post liposuction had fat showing up somewhere else in their body. So it is something to consider, and I think it's really good that these authors mentioned it. And so for this reason, the authors feel like it's pretty important to have some kind of lifestyle intervention prior to the surgical procedures, and then something that continues on afterwards. So if you are changing the way you eat, then you're less likely to have fat come back and then come back in another place on your body. So they said if you don't, and one place that it's bad to come back is around your organs. So they specifically talk about, we do not want to have that visceral fat. That makes your organs not function so good. So they're especially concerned with that. And so and this is coming from Dr. Amato, who, remember, said there's other ways we can treat lymphedema, including a ketogenic diet, and maybe we won't need surgery. But if you do have surgery, you got to do everything you can to reduce that inflammation and prevent the fat accumulation from coming back and maybe from other parts on your body. So they did that. And then also they talked about there could be a potential conflict of interest. You think about these surgeons who are the ones writing these papers and reporting on how their surgery goes. They have a vested financial interest in telling you that all of their surgical outcomes are good. And so when they write these papers, there could be a bias in there and a conflict of interest to saying, just reporting all the good outcomes. So it really behooves you to really do your own research. And they really said there's a very strong need to doing more about the long-term effects. 3 months is not enough. There was that one paper that had 12 years. Fantastic. That was great to see how things are going a decade later. So that's wonderful. And then some other limitations that they found when looking at these studies. One was that they were all based on self-report tools. So there was no really objective or third-party assessment of the various outcomes. And so it was, that's the only way you could do pain is pretty much a self-assessment tool, and quality of life the same way. But when you're looking at edema and swelling, hopefully you would have objective measures for that. So, but this reliance pretty much solely on the self-report tools may mean that it's not as accurate as we would like it to be. And then also they were all single center studies. So it was in one surgeon's office, all the patients, and then they did a study out of those patients. And so that really limits the generalizability because different surgeons might be using different techniques and they would have different outcomes. And then unfortunately, there was a high rate of dropout on these studies. And so they started out with a lot higher number, but then when they went to go follow up with them, they couldn't find them, couldn't contact them. And so we don't know if they had an adverse event. We don't know if they had a poor outcome longer down the road. So we don't have good follow-up because of those dropouts. So they came to the conclusion that while it appears that we have really good results on decreased pain, bruising, edema, improved mobility, it's just that lymphedema is more complex than just these outcome measures show. And so we need to put this into all that information, and we still need to study it more because there was significant limitations to these studies. And so we need to really look at this more before we say that this surgical intervention should be part of that first line intervention. So this is interesting coming from two surgeons who say, wait a minute, put the brakes on. This is maybe be good for one of the interventions, but not the first one that we go to. So I thought that was really interesting, and I hope it was good information for you. If you would like we're having the link for the paper. If you want to read it yourself, you can do that. We'll have that for you below. I know there are a lot of you out there that are looking at surgery, so this is just one more analysis to put in your information you're all putting together. And I just want to put in a quick plug before I look at your questions, because of one thing that Dr. Amato and Dr. Benini said in this paper about that pre and post surgery lifestyle intervention is pretty significant and is going to add to your outcomes for the surgery. Check out our heart-to-heart event that's coming up, because we're going to focus all on nutrition, but it's keto and beyond, and how to make this work for you in your individual situation, how it works for you in your family, in your culture, in your social situations, for your particular health issues. All those things are going to be discussed at this Heart to Heart virtual 3-day event conference coming up on April 12 to 14. It's a collaborative conversation that's happening between clinicians and vendors and patients and caregivers. We're all getting together and talking and discussing these issues. So please check out that link below and join us. Sign up. We'd love to have you there. And then I'm going to just really quick, I'm going to go through the comments here. Hi, Sue from Roswell, Georgia. And Adrian, oops, she said I was frozen. Yes, that's tending to happen. I'm having Spectrum come out and try to fix the issues. Let's see, Alex and Sherry is here. Hi, from South Florida. And Adrian is in Canada. Karen is in Michigan. Wanetta. So many women travel for lipedema reduction surgery. We need to understand and be prepared to address the complications at a distance from our surgeons. And you are so right, Wanetta. So it's trying to find someone who knows lipedema and has experience doing liposuction for people with lipedema can be a challenge, and probably not going to be someone near you. So you got to be able to, am I going to be able to stay for, a certain extended period of time in the area of the surgeon to make sure that everything's doing okay? Or am I going to have the support necessary? So if I go home, am I going to have that help and be able to deal with any complications should they arise? So these are all things to consider as part of your overall plan. Excellent point. Sandra says that more research is still needed. Yes. And Sue said, could I say that doctor's name again? And I think we got posted Dr. Armato. That's wrong. It's Amato, Amato. He's from Brazil. Dr. Amato, Amato. And let's see. And another listener says, I'm 68. I had liposuction on my thighs because of saddlebags when liposuction was fairly new when I was 28. So I don't know how long ago that was. A surgeon told me he took out quarts of fat and that I should stop eating so much fat. Yeah. And that is, unfortunately, at least years ago, that was that unfortunate belief that you eat fat, it turns into fat in your body. And unfortunately, we now know, and actually we did know 100 years ago, that it was the starches and the carbohydrates that turned into fat in our body, not the eating the fat. So that was not wise. And then another person says, by 35, I had fat cuffs. And I'm thinking, are you thinking about that shoulder at your ankles? So that is something that sometimes with the liposuction, they will make sure that there's no fluid in there. So because some of it could be swelling, you try to get that all out through conservative therapy, and then you might have liposuction. If you still have a shelf there at your ankle, you might have that removed. Yes. And let's see. Liz and Brandon McGuire say, thanks for sharing this information. And Nancy says, hi from New York. And I don't know if my insurance will allow me to go out of state. That's another issue. And it does require quite a battle for you, and hopefully with your doctor supporting you, because your insurance is required. If they don't have a provider for what you need in your area, they're required to allow you to go out of your area to get the help you need. But it really requires a lot of documentation from your healthcare providers. They got to really help you with fighting this type of thing. Dabney, hi Dabney, I've been emailing with Dabney. My surgery journey has been very challenging. Inserts approved and then paid less than $2,000. And you know what, Dabney, as a provider, as a clinician, I would get insurances that would say that, yes, we're going to pay for this patient's therapy. And then when it came time to submit, then all of a sudden they wouldn't pay. So this insurance is tough. This is a very big challenge, and it's unfortunate that this roadblock is put in people's way. If you say that it's covered, it should be covered, and they shouldn't go back on that later. Juanetta says, if you are in a PPO and there is no one qualified to either diagnose or treat, you can ask for an out-of-network exception. Yes. And then you need your healthcare provider, your primary care physician sometimes, or other provider, to help give the documentation on why this particular specialty is needed, and that where you want to send them to, that's the best place to go to. It requires a lot of documentation. Yes. So thank you all for your comments and questions. Another great day. Be sure to, a lot of times I will transfer these into flash briefings, and those are the recorded little mini podcasts that take maybe about 10 minutes. Be sure to sign up for our flash briefings at lipedema-simplified/flash. You can just get them regularly sent to you. But you can also go on the website where I just told you, and that you can see all the archive, and you can look through and find the flash briefings that have the topics that you're interested in, and you can listen to those. They're all very short, so it's kind of a neat way to start your day. I am just now, I'm scrolling down. There's, you guys are all still very active here and making comments. It's been lovely. Remember, I'm here on the first and third Thursday of the month, and I will see you next time for another research update. Bye-bye, everybody.